All right, you all are here for Enhancing Safety in the Homeless Response System. I'm Michelle Williams, and I'm a HUD TA provider, and I'll be your moderator for today. I'm joined by fellow TA providers Ann McCready and John Gilvar, who will be our presenters for this session. So just to give you a quick, I'm sorry, on the agenda, and I'm sorry, I'm managing multiple screens here, and so I'm trying to, hopefully you all can see the agenda. So our agenda for this session is going to be an overview, community examples, a deeper dive into racial equity, and some time at the end for questions and answers. So if everybody's ready, we will just jump right in. So when we talk about enhancing safety, we're really talking about incorporating the evolving public health guidance around shelter best practices for reducing transmission in congregate settings as well as social shelters, but also in encampments, and recognizing that permanent housing will ultimately provide a safer environment than any other um, congregate shelter or encampment may provide for people when it comes to reducing the risk of disease transmission, because crowding and the close proximity to others, less access to hygiene facilities heightens the risk for a population that already is at very high risk of disease and death due to increased health conditions, severe medical conditions. So HUD identified 8 key strategies, and these go kind of all the way back to the beginning of the pandemic, if we remember that. We identified 8 key strategies to really help communities focus on enhancing safety for people who are experiencing homelessness and staff that are serving with them. So I'm going to go give you an overview of these 8 strategies, and then John and Ann are going to give us community examples to highlight how communities have implemented these strategies. So as we share this, we recognize the environment that we are currently in which things are changing rapidly day to day. Some of this feeling like what happened at the beginning of the pandemic, guidance about continuing to wear masks, even for vaccinated folks. So we these 8 key strategies are going to continue to be very important in communities for making sure that we're protecting people who are experiencing homelessness and the staff that serves them and the general public as it relates to infection transmission. So our first strategy is to develop and sustain close coordination with public health and healthcare providers. Certainly, folks in communities who are operating homeless service programs are generally not public health experts, and so there really needs to be a close partnership with those entities to provide direction and guidance for on the ground supports. Uh, the second key strategy is to prevent spread of the virus within the sheltered population and other congregate settings. And so we'll talk about how that was achieved. The third priority is maintaining our essential services. So we don't want to, when the world shuts down, we actually can't shut down because we are responsible for making sure that people who are experiencing homelessness within our shelter programs or other settings, and also those people who are unsheltered and on the street, continue to have the services that they need. So even in the midst of COVID, people who were on the street still needed blankets and warm clothing and access to shelter that's provided by outreach personnel. It's very important for us to deploy targeted coronavirus testing. So that is continuing to be a priority within communities to ensure that we have a way of helping people keep tab on their health status throughout the pandemic. Ensuring the availability and proper use of personal protective equipment. I think we're all probably have our supply right now of personal protective equipment, and certainly within homeless service programs, we want to make sure that we have enough of those supplies because people do go through them, as we all know. If the population that we're serving can't always reuse or be able to take proper care of masks, don't have access to washing their mask every day, that type of thing. So really making sure that we have lots of supply of that equipment available for people has been really important. Another key strategy, and for me, is kind of the most important, which is really about accelerating the rehousing process, especially for those people who have that higher risk of COVID-19, severe illness, or death. And so, rehousing for people experiencing homelessness is the absolute #1 way to protect them from all sorts of harm, but particularly people who are at risk. Getting them into safe housing usually will make sure that those folks can live their lives unaffected by some of these issues and their homelessness. Um, the seventh strategy is that we wanted to keep people out of the shelter system and off the streets through prevention and diversion. So figuring out how we can target the resources that we have so that it's not a lengthy process for someone to move either out of the shelter system and into housing or from the street and into housing that will be safer for them going forward. And then as the vaccine rollout proceeded, our eighth strategy was about ensuring access and reducing barriers to vaccination for all of the folks that we're serving and staff. So we're going to talk about some of the community examples. So I'm going to turn it over to Anne to go through our first set of examples.
Thank you so much. So I have the privilege of working with Collier County, Florida, as their regional team point of contact. And I'm excited to share with you some of the ways that they've been implementing these strategies. What I love about this framework that HUD has offered for communities to think about how they're responding is probably no single community is doing great at all eight. Maybe there are some unicorns out there that have all their wheels, turning on 100% in the same direction. But I think what you'll see in our highlights today is that the different communities we're highlighting are particularly good in different ways to show you how they're operationalizing these strategies. So Collier County is the largest county in Florida. It's a mix of urban and rural communities. And they've really focused on the third strategy of outreach to their unsheltered population and the sixth strategy of rehousing folks quickly. In the period since basically the last 12 months, since July of last year, they've delivered 700 PPE kits and 10,000 meals through their outreach workers. They also, purchased and utilized 22,000 masks and PPE kit and 5,000 PPE kits for community partners, including their local EMS that, were interacting with the homeless population in the unsheltered encampments. Let me move my slide. There we go. And then for rehousing, this was where they just really doubled down and focused on engaging landlords. And one of the tools that they used was shared housing as a tool, using natural groupings of folks who are already choosing to stay together in encampments or in parked cars behind the Walmart. They allowed those folks, they gave them the option, like, this is an option we have, it's a shared house. Would you guys want to live together in this house? So it really leveraged their self-determination of folks who are staying outside while still meeting the goal of reducing the risk of transmission through rehousing people quickly. And between May of last year and July 1st of this year, they rehoused 218 individuals from encampment, which blows my mind. Like, that is just an incredible amount of people.
That is amazing. And can you talk about what contributed to that success? I mean, when we're talking about folks who are unsheltered, they can be a little bit more difficult to engage, but can you talk about what worked in Florida?
Yes, thanks. So yeah, the COC executive director had a vision to, to hire someone who had a recent experience of homelessness. And he hired Mitch, who had been homeless and sleeping outside on Christmas Day, 2019. So that is like really recent experience of homelessness. And he had been homeless for, a number of years, sleeping outside. And what Mitch brings to the work is really personal experience that helps build trust from the folks who are sleeping outside. And he could speak from, what you don't have to have it all figured out to take the next right step and take the next right step. So I think that's really what has contributed to their effectiveness in rehousing these 218 people. And I think, I credit their executive director, Michael Overway, for his faith, a leap of faith of hiring someone who was so recently homeless. And I think that could be an example for other communities to follow.
Definitely. I think that, like, having a champion, right? Someone who folks can relate to and trust, while we all mean well, people don't always trust us because we haven't necessarily lived the experience that they have. And so I think that's a really great point. And I really love that they were focused on action, right? Not
Yeah.
waiting to get a perfect plan together, but really taking action as quickly as possible.
Yeah. I would also just highlight, because this has been not, I know that this is a touchy topic across the country, but they have had a particularly healthy and mutually communicative relationship with their sheriff's department, and the way that they've engaged mindfully around that has also been a good example in the street outreach area. So yeah, great things coming out of Florida right now. I'm going to transition us to talk about my next example, which I'm really also excited about. This is Washington, D.C., obviously urban community. Their last point in time count showed about 3,800, 3,900 individuals and 400 families. And one thing they just wanted to point out is an almost 50% decrease in family homelessness compared to the year before. And really, they attribute this to the use of prevention and rapid rehousing dollars that came through the CARES Act to help families get rehoused during the pandemic. Now, we're going to focus on their work today on number 2, how to prevent the spread within the shelter population and other congregate settings, and for the targeted testing. So for preventing the virus spread within the shelter population, they quickly stood up non-congregate shelter, using hotels and other spaces that they were able to modify to have this non-congregate shelter stood up very quickly, which decompressed the shelters, allowed for social distancing within the shelters. Shelters also transitioned to 24-hour models so that shelters that had been closed during the day and folks were traveling to find meals or other things, 100% food delivered where folks were staying, social distancing happening. And they actually opened an overflow shelter that was sort of semi-permanent. It is now in the process of standing down. But because they were social distancing, in addition to the the hotels, they also stood up a emergency shelter for women to decompress the women's shelter side that had more in need of that. So those were the strategies for prevention, decompression, social distancing, staying open 24 hours. I think some of these things are going to continue post-pandemic because there just turns out to be better practices. And then the other area was deployed targeted coronavirus testing. So there was an office hours about this late last year, but they did this great thing. Their HMIS lead and COC worked together with the shelters to do a daily health screen of each person and a communication from the provider back to the COC and HMIS lead, daily data of how are people doing? Are they in emergency shelter? Have they been transitioned to non-congregate shelter? What's everyone's status? And this use of data helped really narrow in on targeting testing to make sure that there weren't outbreaks. They would sometimes test the whole shelter, or sometimes they would do targeted, groups within a shelter based on contact tracing. The other thing is that they hired these mobile nurses that actually went around and during different times of the day were available to do the health screens, and at other times staff in the shelters were trained to do those. So I think this really use of data and targeted coronavirus testing really helped stamp down the outbreaks really quickly. And by June of last year, they were really managing this targeted testing well.
So, Anne, how much do you think of these kind of adaptive practices, right, that they've been able to implement very quickly? How much do you think that they will maintain? And I want to say as we move out of the pandemic, but maybe even as we move in and out, because the guidance changes and the world's changing, and so how much of this are they able to sustain longer term?
Yeah. I mean, this is the conversation right now. It's ongoing. And I think the intention is to stand down some of the non-congregate and emergency shelters that were stood up. But I think that process is being done mindfully and kind of with an eye to changing environment. I do know that with the CDC's most recent guide, it really guidance from, I don't know, 6 weeks ago, like even for especially vulnerable populations, they were still recommended to keep masks on inside the shelter setting. And so that has continued to be the guidance for providers in DC, really just trying to follow and monitor, you know, what the best science is at the time and what guidance we're getting. And then, you know, slowly, mindfully sort of making adjustments as things become, new information becomes available. I would say the one thing that you said about like maintaining after or as we go in and out of the pandemic, you know, the daily practice of data collection has stopped, but I think the relationships that were built, the stronger relationships between the HMIS provider, the providers on the ground, like that process of figuring out how to do that, and could we do that in another emergency if we needed to, and the utility of that, like that learning process will benefit the system into the future. So I think I'm going to turn it over to John.
Yep.
Great, thank you. So I'm going to talk a little bit about an example around vaccination strategy from Detroit, but I wanted to just follow up a little bit first on some of the questions in the Q&A box around the unsheltered, people who are unsheltered, and the extra challenges of increasing vaccination access with that population, where you have fewer numbers of people congregating in one place, people are more spread out. It's just a completely different strategy. And there's two resources, two documents that HUD-SNAP's published that are that I put in the links in a response to one of the questions. Hopefully everybody can see it. I'm going to just try and share my screen as well, if I can do that. And I'll hand it back to you in a minute. Let's see. Can you see that slide, rehousing for unsheltered people? So that's from a slide deck from a presentation yesterday in this conference. But I wanted to just throw it up there for a minute, because one of the people that asked the question was talking about, or making a comment, was talking about how important it is to engage people with lived experience to create strategies for people living unsheltered. I think that is really critical, and also critical to engage the direct service providers on the in many communities, there's various outreach teams with various different agencies, and to a certain extent, the police department or the fire department or EMS, or, there's soup kitchens that are with volunteers, and it's a whole network of agencies and individuals who not only interact with lots of people who are unsheltered, but have a lot of expertise in terms of engaging and building trust with those folks. And I think that all of that is critical, coordinating among those teams, and really making, really using a trauma-informed lens in terms of creating strategies, which again comes back to partnering with people with lived experience. So I'm going to stop sharing that and give it back to Anne, and then go on to Detroit. Also happy to talk more about during Q&A, more about different strategies that different communities that I'm aware of have utilized around the unsheltered population. So this is about Detroit. This is just a basic, sort of basic information here. Could you go to that next slide, please, Anne? So this is a collaborative, oops, one back. This is a very collaborative strategy. So, we've marked here the coordination piece, the unsheltered piece, the testing piece, the vaccination piece. There's other, I mean, they really cover the waterfront in Detroit, but it was a real collaboration between the public health department, a local hospital, the city homeless solutions division, shelter and day center operators, and other service providers. Our representative group from those collaborating agencies gave a presentation on office hours. If we can, we could throw the link to that in the chat. It was an excellent presentation. But a lot of the things that they talked about really I thought it would be great to kind of zoom in on vaccine hesitancy, because that is such a huge topic right now, not only in the homeless population, obviously, but for everyone. But if you think about using this trauma-informed lens, the problems around trust and fear that are going to come up in regards to what you could call institutionalized healthcare, kind of government programs and so forth that affect people who've had experiences, traumatic experiences with the healthcare system that are homeless. I think it kind of can be multiplied when those people are Black or brown or indigenous, and they have their community has this history of incredible breach of trust by government agencies and flat out, lying to people about what was actually happening. So there's a lot of great strategies that Detroit developed, anticipating that there would be vaccine hesitancy. So those different partners got together. They determined that making the vaccine as accessible as possible meant going on site at shelters and day centers and other places where people congregated. Obviously, that required a lot of coordination, but the public health nurses, and in some cases the hospital nurses, were able to go on site and do education during the run-up to the scheduled vaccination event. And that they found was really critical. They could ask a lot of questions. They also held shelter focus groups to draw out those fears and identify trust concerns prior to those vaccination events. Then on the day of the event, the shelter staff or the day center staff, whoever it was, the people that, staff members, case managers, whomever that had some trust already built up with those people using those sites, they went first and they got vaccinated first, and people could see that they were getting vaccinated. And then not only did they get vaccinated, but they turned around and started to work the line, or work the room, if you will, and just look for people who were like on the fence, not twist their arms, but just encourage them around, again, sort of just reminding them of the advantages for themselves and their communities of getting vaccinated. But then they realized there are people that are going to be what you call wait and seers, right? I want to see what happens with these staff and my friends that are getting vaccinated first before I go. And so the way that this collaborative group dealt with that is they went back to the same sites, and again, they kind of just repeated. And they picked up a lot of people who were seeing that their friends and neighbors and so forth were fine. And they also used a really collaborative strategy around using a release of information form on HMIS and vaccination cards that folks were issued to do what they call the find and remind second dose strategy for those vaccines that require a second dose. So all of that was just highly coordinated, but it involved people sort of at the level of these agencies that could mobilize resources quickly, and people that really knew on an operational level, how to get the right staff in the right place at the right time, and communicating ahead of time so that the nurses and the shelter staff and so forth were working hand in hand. I also want to just say that this is just something that was said earlier that just reminded me that we really need to underscore this is people are exhausted. The staff, shelter staff, other staff, public health staff, it's been an exhausting, what are we at now? 18 months or so, right? And when we present these examples, And you know, I'm prepared to talk about other examples, Indianapolis, Seattle, et cetera. We're not suggesting that, you know, everything that you see has to be replicated, or that that it somehow was easy for these communities. It was not. And you know, we're presenting it very quickly to kind of get to the best practices, but all of the folks that I've talked to in all these different communities around the country had a lot of hiccups. They had a lot of adjustments that they had to make. They had to work out kinks in their communication across agencies, et cetera. And they did that while, you know, sort of there was this fatigue, and there continues to be that fatigue. And I just want to call it out and thank people who are on this call for hanging in there and really, really showing incredible commitment to their clients. Okay, so that's it for Detroit.
Thanks, John. I have just a question. I'm just reminded in this presentation about the work that you and I both were a part of through the HUD vaccine rollout team that worked with communities across the country. And some of the information gathering or focus groups that we did during that time, the most important thing that came out of that is that vaccine hesitancy does not equal no. And so really understanding that and highlighting the consistency that was used in Detroit. So people are hesitant, but it doesn't mean they won't get the vaccine. I remember a person specifically telling me they didn't believe a single word coming out of my mouth, but they were still going to get the vaccine. So, you know, it's a really kind of far continuum, really a range of people and where they are personally on these decisions. And so just I think as we see here, and I'm wondering if in the other examples you have, Indianapolis, potentially Seattle or Minnesota, if you saw the same level of a consistent approach.
I think that a lot of communities really tried to go back. And I know Seattle is an example, go back to the same sites. And, you know, I know for sure from the Detroit presentation that they picked up a lot of people when they went back.
Right.
And as you're saying, it is challenging, you know, from a logistics point of view, especially in communities where there's lots of different sites. And I'll share an example in a little bit from Seattle about how Seattle did some equity-based, they did a matrix to try and make sure that given there's limited nursing resources, for example, to go out, that they really were mindful about equity when they decided where to go and whom to partner with. So so yeah, there is that concern, but I think you make a great point.
Yeah, so that transitions us right to a racial equity component.
Yeah. Michelle, I don't know if we want to answer one of the questions in the Q&A from Keith Holland,
sure.
Which related to, I think, the Collier County slides and the folks in shared housing. I just quick response to that. They did receive rental assistance. It was part of a rapid rehousing strategy. So they received temporary rental assistance or short-term rental assistance and case management to stabilize in that shared housing. And I think the key there was finding landlords that had, you know, houses with 3 or 4 bedrooms and, you know, a willingness to have multiple leases and work with the system to get those houses. What I remember from my work with them and in their conversations was once you find a landlord that's willing to work with you, they've had, you know, a handful of landlords do a number of groups, right? And so I think the investment up front on building a strong relationship with your landlord engagement, not every landlord's going to want to do this, but when you find, you know, a medium or larger size landlord that has multiple properties, it can be a real win because especially now the housing market's very competitive. And so finding landlords that are going to want to do something a little different might take a little extra effort. And they really just did outreach. They used their community network. They used their COC board members to help them network, to find landlords who'd be willing to take on this shared housing strategy. And then once they found landlords that were willing to work with them, they really nurtured those relationships to get multiple projects or multiple houses within with like a single landlord. So I just wanted to respond to that question before we moved on. I haven't read the other two that are here. It looks,
and could I take a shot at one of those? So Renee made an excellent point about the unsheltered homeless population needing the vaccine to come to them. That was one of the things I didn't have a chance to mention it in the Detroit slide. Absolutely, they believe that. I know multiple other cities. I've recently talked to people at Seattle Public Health, San Francisco Public Health around the way that they've tried to employ that strategy, piggybacking, for example, on healthcare for the homeless, outreach, mobile medical vans where they're available and they can go out, or other, kind of more street medicine kinds of teams that can go out to provide vaccinations. But the point that she's making is true, because the person in San Francisco said they're actually right now having a surge of cases within the unsheltered population. So this remains an urgent matter for sure. Okay. Is that good to move on at this point?
Okay, and we'll come back to that other question in just a few minutes, but let's keep going.
Great. So it's critical, as it says here, that the planning that we're talking about between agencies really, even though there's a lot of urgency, as we've been talking about, that there needs to be, the process needs to slow down enough to look at the data around racial disparities, right? Look at the data around homeless, hospitalizations, and death throughout the entire population in terms of Black and Brown and Indigenous, much higher rates of hospitalizations and death, the higher rate of homelessness among people of color, the differentials in terms of access to affordable housing and lots of other metrics that are related to a family or a household's ability to protect themselves from, for example, how many people are sharing a small space and how many people got sick because of that. So all of that really needs to go into grounding the planning and making sure that the agencies and communities that are most affected by these disparities, agencies that are working, that are centered in these communities, are at the planning table. Next slide. So, and then just a reminder, equality often refers to, leveling access to opportunities, but equity, in this case, talking specifically about racial equity, we could talk about other, equity along other other areas where people are marginalized, but racial equity would be achieved if one's racial identity no longer predicted one's housing, economic, or health outcomes. In this case, their COVID outcomes. There's a link here to a really excellent HUD document about, how to use some of the tools that are required really in order to eliminate the policies, practices, attitudes, and cultural messages that reinforce differential outcomes, and really make planning processes much more inclusive of Black, Brown, Indigenous folks that are most affected, people from those communities, people that serve those communities, people with lived experience from those communities. I think this gets to a reality that achieving equity often requires significant changes in the distribution of resources. And that's to address the root causes of historical and current disparities. Those disparities in COVID outcomes didn't just appear overnight. They are reflective of structural, historical discrimination goes back generations. And so how could we possibly address them in the midst of COVID without thinking about distributing resources differently from what we do? So next slide. So we have to start with disaggregating data by race for homeless vaccinations, things like non-congregate shelter, where communities have set up protective shelter where there's opportunities for private rooms, other ways of social distancing to protect people from transmission, especially people with underlying conditions and older people. But there sometimes can be disparities in terms of the admissions to non-congregate shelter or the exits to permanent housing from non-congregate shelter, et cetera. So it's really important to use those data to really evaluate as you go. And I want to just share my screen here and do a quick review of a sorry, it takes me a second to, there we go. All right, I'm going to blow this up a little bit. This is from the Seattle-King County Healthcare for the Homeless Network. And their COVID vaccine strategy is a way to operationalize what I've just been talking about. So I thought it might be really helpful. This is from a national presentation they recently did, and they were gracious enough to share with me. So on the top right, you see people plus systems, inviting the right people to the decision-making table, seeking opportunities for systems change, building on best practices and previous successes. In this case, they built on their existing model for hepatitis A and flu vaccination, plus their philosophy of care, which is trauma-informed. And they strengthen their foundation by intentionally identifying areas for improvement, balancing a sense of legitimate urgency versus where the urgency was not necessary and where it was important to slow down the planning to make sure that there was the inclusion that was needed. This involved bolstering coordination and collaboration with community partners, creating opportunities for stakeholder engagement in the vaccine strategy development, and something they called real talk COVID vaccine, which goes back to some of the points that Michelle was making before, uplifting voices, questions, insights of providers and clients of color. I'm going through these really quickly for the sake of time. But ultimately, they created this matrix where they determined sites for immediate distribution, or prioritized distribution of the vaccine. They wanted to target based on using an equity lens, or specifically a racial equity lens. So they created this scoring matrix, and they looked at, their data. Are Black, American Indian, Alaska Native, Latinx residents, do they together exceed 25% of residents of a given site or given area? Is there a special population served? There were points given, where there was domestic violence, HIV/AIDS, veterans, et cetera. I'm not going to go through every one, but they really try to use a racial equity lens to come back to, I'm going to stop sharing and come back and give it back to Ann. They tried to make sure that they were prioritizing the distribution of resources in a way that would ensure that the communities of color were not unintentionally coming up behind the sites that came first to mind, right? Which is a real concern, and we've seen that in some data around non-congregate shelter, where no one intended for say Latinx people to be served by a non-congregate shelter at a lower rate than their proportion of the homeless population, but it happened, right? And then they need to adjust. So I just thought that was a great concrete example of how one community has tried to operationalize what we're talking about here. you can go ahead and advance, but I think that might be the last equity slide. Yeah.
Yep.
Yes.
I just wanted to add into that, like just thinking about our experience and looking at communities across the country where the system itself, the process wasn't necessarily rolled out in the most equitable way. So when I think about communities where your scheduling of vaccine only occurred online, and there wasn't, other options for people to be able to even sign up for an appointment, and how communities adjusted very quickly. Or the other example that comes to mind is communities where it was kind of an open, you could almost go anywhere in your community. And so the slots that were kind of designated in, a particular, in this community, African-American area, were taken up by folks from other areas. And then the folks that lived there couldn't get appointments in their communities. And so I think there's a lot to think about as we continue in this process of making sure that we are focusing in on the health disparities that exist in our community and targeting those folks who are most affected by those, which are certainly within the homeless population. Those folks are overrepresented. Black and brown people are overrepresented in homelessness in every community. And so I think that's great. I think we are at the time for Q&A. I know we've had questions going in the Q&A chat box. But I'm not sure if we are taking questions verbally at this point. We are. Great. No, we're not. Okay, I don't know. So someone who has the control of technology will have to tell us.
I think we're just through the Q&A feature at the bottom, so folks can drop questions in. Yes, correct. Okay, good. But please, yes, drop in additional questions and we will answer them. Renee Mitchell, when I did outreach, I met an unsheltered homeless man with a bone disease disability. Yeah, Renee, this is a great example. And I think I really appreciate you bringing your personal experience to the workshop today. And, I think that that's right, that folks who are, yeah, John, you can take this too. If I saw you just like that.
Sorry, that was a tech issue.
Okay, tech issue. Okay, we're all navigating. This is like fancier tech than I'm used to. So, so yeah, I think that is exactly what the kind of outreach strategies that we are talking about here, and that the best practices is meeting people where they are. And, if that means bringing the vaccines to people in the communities, there's mobile vans, as we've just talked about. There are some communities who are figuring out how to transport limited doses, and while maintaining whatever, protocols have to be maintained for those vaccines. And it does take a little more effort, but I think the excitement of this moment, if there's a silver lining, is that the first wave of folks, who were banging at the door to get their vaccines, that first wave has maybe passed. And now, if you think about 6 months ago, we were in vaccine shortage and we were like trying to triage and prioritize. And now we might have a little breathing room to try to reach these folks that need that individual attention, that need the opportunity to get the vaccine brought to them in order for them to feel like they can say yes, because of, whatever their circumstances are. So, maybe a silver lining of this moment is, yes, we have more people unvaccinated than we would like at this point in the game. And now we can really focus on them, understand what we need to do in order to help them get to a yes for the vaccine, which might be logistics and it might be listening, like we've talked about during this presentation.
I think the thing that we've all learned, I would hope, during this process is how intimately connected, our personal health is with the health of all the rest of the people in our community, whether they're housed or unhoused. And so to me, it's been a great way to really talk about the humanity that we all share, right? And how in a community, I'm not in here by myself, right? It takes all of us coming together and to support those who are more vulnerable and who need some extra support to be able to get to health access in the way that is needed. So,
yeah, I think that um, that's such a great point, Michelle. And also, you know, we've focused a lot on the examples that we've given on sort of on the ground collaboration at shelters and encampments and so forth. And I think that, to go to your point, the collaboration actually has to happen too at the tops of those agencies with that exact recognition, the recognition of that exact point that you're just making. And you know, it really goes to, you know, I think about Indianapolis as an example that I spent a lot of time talking to the folks in Indianapolis, where you had the COC director, the mayor's, someone that was very high up in the mayor's office, actually multiple people, the public health department, individual homeless service providers. I'm probably leaving somebody out. And really, the way that they not only quickly created plans around things like non-congregate shelter and isolation and quarantine, where they used hotels for both of those, and they connected with outreach teams to get the most vulnerable people in. But the way they braided funding, because none of this can happen without funding, right? So we're talking about emergency solutions grant, ESG money, Treasury money that was available at the beginning, now American Rescue Plan money, FEMA money that they used, and they really had to, really had to roll up their sleeves around, okay, what is the FEMA money going towards versus the ESG money? Because FEMA will only cover certain parts of, FEMA funds will only cover certain parts of this strategy, but ESG money will cover another part, but we might have to fill in with some city money. And that was enormously complex, and it continued to change as the pandemic went on, and as the new funding might become available, or rules were clarified, and you know, information was distributed from various different places. But that level of coordination at a leadership level really allowed them to pivot quickly and make sure that the great strategies that the folks at the individual agencies were coming up with were funded.
Right.
So I think that's an important piece of this.
Yeah.
I don't know if people had any questions, that participants had any questions related to that, but we'd be happy to take those too.
And I would just add on, you made a great list of all the funding sources that are being braided right now. And I would just add the emergency housing vouchers from PHA and the Public Housing Authority. You know, those collaborations right now are really exciting. Like when I hear about COCs and PHAs who have really never worked together, figuring out how to use those emergency vouchers together with some service dollars to take folks who from unsheltered into public housing. And, you know, I'm really impressed. I know we've said this is probably the third time this webinar. Folks are tired. Folks on the ground are tired. I am so impressed with the communities who are taking on not just placing the easiest to place folks into those EHVs, but really digging deep and figuring out how to use their street outreach strategies to place folks and stabilize folks who can use that long-term subsidy, who need that deep subsidy indefinitely, but figuring out how to use those vouchers for you know, some of the really vulnerable folks in their community. And you know, to do that this late in the game, to find a little bit of reserves of energy to work together and figure out those new collaborations. I've been really impressed with communities who are figuring out the braiding of those funding to make those EHVs really leverage for serving the most vulnerable in their communities. So shout out to all the folks who are digging into that work.
We have one kind of last question that's come into the Q&A box from Renee. I think, you know, certainly I know some of this is, no one wants to see any money be wasted under any circumstance. I think there is a certain level of trial and error that happens within a situation that is constantly evolving. So My thing I would say, Renee, is that continue your advocacy, right? Continue bringing these things to light, because I think everyone wants to make sure that all the dollars go for the best possible purpose based on what we know in that moment. And we don't have any other questions at the moment. So I think that means we appreciate you all being here, taking the time to listen to us today. And we're happy to provide any more information or more discussion if you need it in the future. Thanks, Ann and John. Right.
Yeah, thanks. Thank you, Michelle, for coordinating us. And thank you, everybody, for the work you're doing and for being with us today.
Thank you.
All right.